Good morning, everybody. Let us just bow our heads in prayer. Father, we give you thanks and praise for this a new day. We thank you for the opportunity for us to come together in this fashion. Lord, there's so many things going on in our country, but we know that you continue to be in control. And so we look to you and we ask you, Lord God, to just bless our presenter as she unfold certain things, makes things a little bit clearer for us, mighty God. And so we just ask you to just bless this session. May it be useful to us all, that at the end of it, we can certainly say it was good that we would have been here. So we just give you thanks and praise right now in the name of Jesus. Amen.
Amen. Thank you so very much, Ms. Fogor, Director of Health Promotion and Education in Ministry of Health and Wellness. And so I'm just going to ask persons to know, I'm going to just refer to you and you just open your mic, and if you are presentable, your video as well, and just introduce yourselves and which media host you are associated with. So let me start with the first person who is appearing on my screen, Mr. Job Nelson.
I am Job Nelson. I'm with Loop News. Hello.
Thank you very much, Mr. Nelson. I'll now move to Anthony Morgan. Okay, not hearing from Mr. Morgan. Let me move on to Garfield Angus. Mr. Angus? All right, is everybody hearing me?
Hearing you.
Okay, good. So let me move on then. No response from Mr. Angus. Jamaica Observer.
Hi, I'm Brittany Hutchinson from the Jamaica Observer.
Welcome, Brittany. Person that, is it Calando?
Hello, good morning.
Morning.
Oh, I'm with the private sector vaccine initiative.
Okay, morning and welcome. Kimberly.
Thank you.
Hi, morning. I'm Kimberly Hibbert from the Jamaica Observer.
Welcome, Kimberly. Natalie C.
Good morning. I am Natalie Campbell of IRI FM.
Welcome, Natalie. PBCJ TV. Okay, not hearing from PBCJ. RJR Gleaner. Miss Williams. Okay, moving on to the Gleaner Company.
Good morning, everyone. My name is Johnny Daly from the Gleaner Company.
Welcome, Miss Daly. I'm looking at Zahra Burton.
Hi, everyone. I'm Zahra Burton. I'm with 18 Degrees North.
Welcome, Miss Burton. I think that is all our media partners. I just go back briefly to Mr. Morgan. Okay, not hearing him either. Mr. Angus. Okay, so let's move to introduce the team from the Ministry of Health and Wellness. Let me start with HPE MOHW co-host or host.
Morning, everyone. Go ahead, Ms. Hogan, sorry.
Morning, everyone. I am Takis Fogor, Director of Health Promotion and Education here at the Ministry of Health and Wellness.
And morning, everyone. I'm Stacey Wright, Communications Officer for HPE at the Ministry of Health and Wellness.
Move on to
Petre Williams-Raynor, Manager of PR and Communications for the Ministry of Health and Wellness.
Ms. Archer. Toshiba.
Hi, morning everyone. My name is Toshiba Archer. I'm the Public Relations Officer and Digital Marketing Specialist at One Integrated Group. And we're the communications partner, partnering with the Ministry of Health on the COVID-19 initiative.
Thank you, Ms. Archer. And so before I introduce our main speaker introduce herself, let me just again welcome everyone and thank you so much for making the time to be here with us. The media is a very important partner in this fight against COVID-19, and you help us to get our messages out there in terms of the infection prevention and control measures. And right now, as we roll out the vaccine, COVID-19 vaccination program and implementation. And so we thought that, you know, it would be good outside of our weekly press conferences to just have a more focused sensitization session with our media partners so that you also are kept abreast and are more aware of what is happening when it comes on to COVID-19 vaccination, and so that you can help us to communicate effectively to the wider Jamaican population and help to dispel some of the myths as well as the misinformation that is out there and the disinformation that is out there. That helps to contribute to vaccine hesitancy as well as contribute to the level of complacency that some of us are seeing within our society at the moment. And so now we are going to have Dr. Melody Ennis, who is our Director of Family Health Services in the Ministry of Health and Wellness, do a brief presentation about COVID-19 vaccination. And then after which we'll go into our question and answer segment. So Dr. Ennis, I'm handing over to you. Thank you so much.
A pleasant good morning, everyone, and thank you so much for joining us. So we're talking vaccines, and we have been talking vaccines for oh so long now, but sometimes, you know, the information is a little bit skewed and we're not too sure what we are doing and where we're going, and it's really a lot of misinformation. So let's get the facts a bit and see if we can dispel some of the myths. So we are quite aware that the COVID-19 pandemic is not going anywhere with the usual things that we have been using in medicine. We have thrown everything at it. The antiretrovirals, the antibiotics, just about everything. We're now at ivermectin, and we're still not making a major dent. Over 2.9 million deaths so far. So we're at the point of vaccines. So what are vaccines and why are we attempting to use them? So vaccines are really just substances that trigger our immune system to produce what we call germ-fighting tools. And I think the easiest way to explain it is to think of it as the Jamaica Defense Force. So we have the army, and the army, of course, is here to protect this little rock, with many soldiers having different functions. But their overarching goal is to do what? Is really to protect us. So they go out and they gather intelligence, and they go back to camp, make their little ammunition, and have it ready to fight if we're attacked. The body, you know, behaves in a very similar way. So our white cells are the soldiers, and they need to gather intelligence, and they actually gather intelligence from the vaccines. So when we get vaccinated, the vaccines tell us or tell the soldiers, this is how the real thing is going to look. And therefore, they go back and make these antibodies. And once we are attacked, then yes, they're ready to get rid of the germ. Now, we've been doing that for hundreds of years. Remember, vaccines save over 200 to 300 million lives every single year. So what is this big, really, hullabaloo about COVID-19 vaccines? What is the difference? And I thought it would be instructive if I actually shared a little video with us as to how vaccines are actually made, what goes into it, what's the difference now that is causing this challenge. So take a listen for me, please.
How do you create a vaccine to fight a new disease? And why does it take so long? Well, first, you have to identify the virus or bacterium that causes the disease. In some cases, the pathogen itself can then be weakened or deactivated and used to make a vaccine. But this isn't always possible. In these cases, the next step is to identify the pathogen's antigens, unique protein or glycoprotein markers which can form the basis of a new vaccine. For some pathogens, these antigens always stay the same. Other pathogens, like the virus that causes flu, can change or mutate their antigens, and so these must be reanalyzed every year. Once you have identified the pathogen or antigens, you need to decide how you are going to use them to build a vaccine. This is called the vaccine platform. There are a lot of options here, like subunit vaccines that only use part of the pathogen. There are also newer or more experimental technologies, like viral vector or nucleic acid-based vaccines. But we'll get to these a bit later. You also need to decide how the vaccine will be administered. By injection into the skin or muscle, orally like the polio vaccine, or through the nose like some flu vaccines. Each of these options could affect the response the vaccine induces. For now, let's say you've decided on the platform and designed the vaccine. Next, it needs to be tested, first in cell cultures and then in animal models. It might include challenge studies, where animals that have been given the vaccine are deliberately exposed to the target disease to see if the vaccine protects them. Further down the line, and if the disease isn't too serious or effective treatments are available, humans might take part in challenge studies too. Once the vaccine candidate is proven safe in animals, you need to prove you can manufacture it to a high enough standard for people and at scale. This is called GMP certification. If the vaccine passes all of these stages, it's time to begin human trials. Normally, these come in 3 phases, and they all have to be passed. First, the vaccine is given to a small group of healthy people to test for adverse reactions. This is called the safety trial. Second, you give the vaccine to hundreds of people to work out what dose is needed to trigger a big enough immune response. Finally, you can trial the vaccine in thousands of people to see how effective it is. This step is often the slowest, and participants are sometimes recruited around the world. Researchers have to wait for participants to come into contact with the pathogen naturally. By tracking how many become infected, they can work out how effective the vaccine is at protecting the group. It can take decades to gather enough data to be sure. But if you do, the vaccine can finally be licensed. There are still problems to overcome, however. Mass producing a vaccine to a high standard can be a difficult job. And once you've cracked production, you still have to deliver the vaccine to where it's needed. And then there's phase 4 monitoring, keeping track of rare adverse reactions that the vaccine might cause, even though it's passed the previous trials. This trial process is very safe, but that comes at a cost. It is also very slow. In an emergency, there are ways to speed things up, like reducing the time spent waiting for paperwork to be completed, or running different trial phases at the same time. But steps are never missed out. By working more efficiently, a protective vaccine could be produced in as little as 12 to 18 months, and advances in biotechnology could speed up production pipelines as well. And there are more ways we could speed up production. let's come back to some of those newer vaccine platforms. Nucleic acid vaccines don't use pathogens or antigens directly. Instead, they deliver the genetic templates for the antigens. These DNA or RNA templates can be delivered directly or in lipid nanoparticles that help them to enter cells and improve their stability after injection. These nanoscale fat droplets encapsulate the RNA or DNA, protecting it as it enters the body. Some lipid nanoparticles can also act as adjuvants, molecular triggers to kickstart the immune response. Once inside the body, these DNA or RNA templates instruct our cells to start making antigens which activate the immune response needed to build immunity. RNA and DNA are much easier and faster to produce in the lab than antigens are. They're also potentially safer than vaccines that contain whole pathogens. That means they could hopefully be used by people with weakened immune systems. But nucleic acid vaccines are still experimental. Another approach is called a viral vector. Viral vector vaccines work by inserting an incomplete segment of genetic material from a pathogen inside a harmless virus that doesn't cause disease. This then acts as a vehicle for the genetic material, delivering it to the right place in the body where it can be translated into proteins, triggering the immune system. The viral vector may even be self-replicating, increasing the amount of vaccine in the body. Viral vector vaccines are also quick to produce. Safe vectors have already been established, and it is relatively easy to insert different target genetic material into these established carriers. And as the genetic material inserted is incomplete, they can't replicate and cause disease, so they're also very safe. But there is only so much the process can be sped along. Effective vaccines can save millions of lives, but before they are used, they have to be proven to be safe and effective. In the future, researchers hope to develop vaccines against non-infectious diseases, like cancers, based on chemical markers called tumor neoantigens. Vaccine technology is developing every day, and it has a bright future, albeit a slow and methodical one.
Okay, so the first myth that we encounter with the COVID-19 vaccine is that it really isn't safe because it was rapidly developed. And we see that it's really a different platform from what we normally use that is being employed to make the COVID-19 vaccine. Again, I go back to what makes it simple for me. I think of walking from Montego Bay to Kingston, and I have to walk through, and of course, without a doubt, it's gonna take me almost 12 years to do that. So, I have to pass through Trelawney and St. Anne, St. Catherine, St. Andrew to get to Kingston. What if I am driving? I now have a different platform, a different way of getting there. It is the motor car. 2 hours, all right. 3 if I stay within the speed limit. So, but I still have to pass through Trelawney, St. Anne, St. Catherine, St. Andrew. None of those parishes have disappeared. They're still there. So none of the steps in making the COVID-19 vaccine has been skipped out, has been missed. No, they're still there, but it's a different platform. And therefore, we were able to make it in a much shorter time. And of course, not to mention the fact that money talks and there was no hoarding of information. Countries and scientists will hoard their information to get fame and fortune, but everybody came together in order to do it. So there was the money, there was the collaborative thinking of all the scientists, there was a new platform that was being used, and most importantly, I want to suggest that it's a phase 3. Remember, for the phase 3, we need thousands of people across the world that would have had to come in contact with the disease to see how the vaccine works. Now, for COVID-19, last year there was no shortage of people. Every other body really had COVID. So Pfizer, for example, could easily find around the world 40,000 persons to put in their clinical trial. Moderna could find 30,000 easily. AstraZeneca could find 40,000 as well. Sinopharm, another 100,000. Sputnik, 100,000. So it wasn't the phase 3 that would normally take about 6 years. That didn't have to happen because persons were available to be in the trials. So let's run through some of the other myths that are plaguing us with the COVID-19 vaccine. One is that, the vaccine may alter my DNA. So if I take the vaccine, I'm going to turn into some other thing, growing extra hands and feet. We can look at what's been happening. Vaccines started to be administered in December, and I'm sure almost every one of us on this platform would know someone who have taken the vaccine, and they're still the person you knew from before, right? So really, the vaccines, be it the RNA or the viral vector, which is what the AstraZeneca is, they simply just instruct the body to make antibodies. They don't get into the nucleus, they don't trouble our DNA. And additionally, they are removed from the body quickly. Within hours, they are removed because once they deliver their message, they are degraded. And we know how unstable these vaccines are. You know why? Because of the temperature. So the messenger RNA proteins, for example, have to be stored at -70 to -90 or -20 degrees. So they degrade very quickly at other temperatures. So they don't stay in the body for long at all. Then, the other one that is common is that the COVID-19 vaccine has a tracking device. So all governments around the world came together to say, let's put something in people so we know every time they go to the bathroom and poo. Apart from sounding a bit over the top, let's look at the science. So there is really no microchip that's in the vaccine. The vaccines are solely used to protect people. But I believe that this myth actually came about through our Chinese telephone here in Jamaica. When we pass a message from me to 5 people, by the time it gets to the 5th person, the message is totally different. And that is because vaccines are tracked. We do track vaccines. We have always done, and we will always do. We track the cold chain, we track the manufacturer, the batch number, lot number. We do that for a reason. So I mentioned earlier that maintaining the temperature is absolutely critical to the good functioning of the vaccine. So our vaccines, for example, are coming from India. They have to go to Amsterdam and Miami before they get to Jamaica. That's a 2-day trip. Now, if the vaccines come out of the right temperature range, they are no good. So we do have tracking devices within the vials and the boxes to tell us the temperature at every step of the way. We also track the other things mentioned, because should I get the vaccine, any vaccine for that matter, and say, for example, I develop blindness. I know I'm blind and I got my vaccine yesterday. Now, you're going to say, oh, is it the vaccine? So what we do, we go back to every single person that received the vaccine from the same lot, from the same batch, from the same manufacturer. And if it's 100 of us, we go and we find all 100 persons and we investigate. Are they having any blindness, anything happening? If the answer is no, 99 of them are right, is me alone have the blindness, then maybe it's not the vaccine. Maybe it's some underlying factor that I had that predisposed me to getting blind. So we do track because our surveillance system to ascribe cause and effect is very robust. So that's the business of tracking. We don't need to put anything in anybody's arms to track. We track naturally for the safety of the vaccines. Then we have the one that the vaccine is developed from fetal tissue, and I can just show you the ingredients or the components of the AstraZeneca vaccine. So it has the viral vector, which is the adenovirus. It's a virus that causes no harm to humans. It's cored out, and they put the genetic material of the spike protein in it, and it's injected into us. So that's that one. Then we have histidine. These are just proteins. Magnesium is a salt. ethanol is some alcohol, sucrose, some sugar, and more salts and water for injection. That's the components of the vaccine. I skipped over polysorbate because polysorbate is a compound. It's a stabilizing compound, but it can give allergic reactions if it cross-reacts with other things. For example, polyethylene glycol, which is found in the other vaccines. Now remember, we do not interchange the vaccines. So you're not going to get one and end with another. It's the same Astra. So if there is no interchangeability, then there is no problem with the polysorbate. This is another big myth that the COVID-19 vaccine causes infertility in women. Now, remember, the vaccine component, which is the adenoviral vector, it is not staying in the body long, 2 hours, that's it. But in addition to the short time it spends in the body, we don't have any amino acid sequence that is shared between the spike protein and any placental protein at all. Also, there is a syncytin 1 protein that is present in the placenta that, if affected, could cause infertility. There is no correlation, there is no link, there is nothing between the COVID-19 vaccine AstraZeneca and any placental protein that could cause infertility. And you know, in all honesty, persons who were involved in the phases 1, 2, and 3 trials back last year have become pregnant and are now having bouncing babies. I have already been diagnosed with COVID-19, so I do not need to get the vaccine. That is indeed not so, because natural immunity wanes over time. So we have noticed that persons would have had the disease, they would have got better, full 100, nice recovery, and guess what? They get it again. That is because their immunity was not sustained, and therefore the recommendation is for us to take the vaccine. Now, this myth is also very common, is that if I take the vaccine, I'm going to get the illness. Now, I just showed you the components of the vaccine. So if it's not into it, if it is not a part of it, then you can't get it. You can't give it if I don't have it. So, you know, that kind of myth is a little bit redundant. But then we move to the other one. Once I receive the vaccine, I will test positive for COVID-19. Now, we could use the same explanation. If it's not in it, then it can't give me, so I couldn't test positive. But let's pause a bit and go through this particular myth. So if I have the virus in me now, and maybe 1 or 2 of us on this platform may very well do, but we are asymptomatic. We're not showing any signs and symptoms of the disease at all. We're good. And I take the vaccine, and then you test me after. Of course, I'm going to test it because I have the virus in me. But guess what? It is not the vaccine that gave it to me. I had it before I got the vaccine. So I can't test positive after taking the vaccine. And there's another way we can test positive after taking the vaccine, and that's dependent on the type of test that you have done. So if I am doing an antibody test, remember, when we give the vaccines, what we want, our bodies to develop antibodies. So we're supposed to test positive if we're doing an antibody test. It is expected, it's normal. So when we hear this myth, you know, we have to kind of like decipher a little bit and figure out what they're talking about and be able to explain it properly. The COVID-19 vaccine have severe side effects like allergic reactions. So yes, in extremely rare circumstances and instances, you can get a severe allergic reaction to any one of the components of the vaccine. But in a similar way that we may be allergic to peanut and shellfish, you know, wasp bite, bee sting, if any of those things happen to us and we swell up like bullfrog, end up going to the doctor, getting medication to help us. Once we recover, we're not going to have the peanut and the shellfish and those things again, are we? No, we're not. So it's the same. If you develop an allergic reaction to the vaccine or components in the vaccine, then we won't offer you the second dose. And then, of course, you have those people who just say, natural immunity are the way if you go and not contaminating my body. Well, we know that natural immunity wanes. All right. We know that it's not sustained. We also know that as we wait for natural immunity around the world, or even in our little Jamaica, millions of persons are dying, hundreds here in Jamaica. So vaccines help to build immunity without the damaging effect that COVID can have. This is another biggie. Once I receive the COVID-19 vaccine, I no longer need to wear a mask. That is not so. We have to still mask wear, hand wash, and physical distance. And that is because once you get the vaccine, then you are protected. You are protected, and that's the 2 doses now. You are protected from severe illness, hospitalization, and death. But you still have or can have the virus in your nostril, in your mouth. And I don't get the vaccine yet. So if you don't wear your mask and me don't have on mine, you not going to get sick, but you won't cough and talk in my face. And I am going to get sick, possibly get hospitalized or even die. So until enough persons are vaccinated and there is herd immunity, which is about 70% of the population, then we all need to wear our mask and do all these measures. So the quicker we all get vaccinated is the quicker we can get back to whatever we consider normal. And those are some of the myths. Persons wonder who should get it. And, we have lowered the age range now. But what I really want you to know is that persons who have comorbid conditions, those underlying illnesses, when they get COVID-19, they do much worse. They end up in hospital for a long time and they die. So if you are obese, you need to take the vaccine. If you have cardiovascular issues, hypertension, heart failure, yes. If you have respiratory illness, asthma, emphysema, chronic bronchitis, yes. If you have sugar, yes. If you're HIV positive, yes. If you have any autoimmune disease, lupus, rheumatoid arthritis, yes, you are to take the vaccine as well. And of course, the vaccine we're offering is AstraZeneca. Good news about AstraZeneca is that it is 79% effective at stopping symptomatic disease. So yes, 79% of persons who contract the virus will not show any symptoms. And that's a good number. But the better number is the 100% effective it is against falling ill. So if you're fully immunized with the AstraZeneca vaccine, even if the virus comes inside of you, you will not fall ill, you won't be hospitalized, you won't die. No, that is a biggie because our hospitals are bursting at the seams, are they not? So this is very comforting with the AstraZeneca vaccine. And we know that we get 2 doses, remember, in the arm. We get it 8 to 12 weeks apart, the second dose. And we are only fully immunized after the second dose, and it's about 10 to 14 days after the second dose. The first dose, after some 28 days, we start to get some amount of protection. So you understand the importance of the mask wearing, hand washing, and physical distancing. Finally, let me just run through the side effects that are very common, more than 1 in 10 persons. The tenderness, the warmth, the redness at the injection site, the whole feeling of being unwell. I have spoken to a lot of persons who have received the vaccine, a lot of young persons who say, boy, when they wake up the following morning, they are so listless. That's the fatigue. You can get chills and headache, nausea, joint and muscle pain. Up to 1 in 10 persons get the lump at the injection site, fever, vomiting, flu-like illness, and then uncommon, you'll get the dizziness, the decreased appetite, abdominal pain, enlarged lymph nodes, which is the wax and calon all over the body, excessive sweating, and your itchy skin. Contraindications, again, if you're allergic to any of the components, or if you have had a severe allergic reaction. I think I am going to pause here so that we can get into the more important part of the presentation, which is the question and answer. So over to you, Madam Chair, and thank you.
Thank you so very much, Dr. Ennis. And, just key reminders on the COVID-19 vaccine and, how vaccines work and the immunization process. I think it's important for us to understand. And it really was a very good presentation in terms of, responding to a number of the myths that are out there. So thank you again, Dr. Ennis. And so now we are at our question and answer segment. I'm going to ask persons to either raise their hands or type the questions in the chat. And once I acknowledge you, then you can proceed to pose the question, and then Dr. Ennis or a member of the team will try to respond to same. Zahra Burton, you had your hand up. Please go ahead.
Good morning again, everybody, and thanks for taking my questions. And I really hope that this is one of those times where it won't be a situation where we ask questions as members of the media, get a response, and just have to take it, even if we have follow-up questions, because I really hope this sensitization session is about being able to understand fully and not just partially what it is that we have questions about, okay? So Dr. Ennis, the set of questions I have for you include, but not limited to this. You mentioned a while ago in your presentation that there was a robust way to ascribe cause and effect, right? When it comes to whether the vaccine caused any problems, right? But one of the persons, the most high profile person that we've heard about so far is the case of Darren Wood, who after taking the vaccine died. We also know he tested positive for COVID-19. The CDC website mentioned that if you are positive for COVID-19 at the time, you should not take the vaccine. What I'm trying to understand is, and I wasn't given a clear answer the last time around, because he is the most high profile case of a death that took the vaccine, how did you go about determining that it was COVID that killed him if you did? How did you rule out vaccine as contributing to his death? Because this is just not clear to me. What is the science of what you went through? And again, I have several other questions, but I really want to just hear an answer to that makes sense.
Okay, thank you so very much for your question. I am going to answer you in a very general way, speaking to the specifics, however, but we can't discuss clients on an individual basis. But we start off by saying, if a person is ill, you are not to take the vaccine. Now, persons mask their illness, and we advise that you do not do that. So if you are having symptoms of the disease or any disease for that matter, and we know persons do it when they want to travel, for example. So I have the flu, I am stuffy, everything is wrong, and I dose up with my antihistamines and my Panadol. And when I go to the airport, I am fine for the 2 hours of the flight, but I'm sick, I'm popping down. So if you mask the illness and you present, you will be vaccinated or you will receive medication. You will have the problems on the plane where your sinus is bursting and you feel like you're imploding because you have shortchanged yourself. Now, remember, I'm answering general. So if you are sick, you are not to get the vaccine, and we need to be honest with ourselves and do not take it. That's number one. Now, how we go about doing the investigations. We look at your premorbid conditions, what you have that will make you susceptible to the cause of death. So your cause of death, or positive cause of death, even if it is COVID, would be from respiratory failure, or it would be from heart failure or multiple organ failure or something like that. So do you have something in your pre-existing self that would put you more at risk if you, for example, take the vaccine? Or is it that those things alone, with or without the vaccine, would have caused your death? Now, those investigations may take a while to happen. We also have to do certain tests. Some of them, not all, can be done, for example, here in the country or in the Caribbean, and may have to be sent outside. So what you try to do in the investigations is to eliminate what we call the compounding factors. So anything that could, and then once those are eliminated, then it would leave the vaccine. And it is difficult, I must say, to eliminate all things. And sometimes at the end of the investigation, it remains inconclusive. But we also look at, remember I spoke to batch number and lot number. So we look at all persons who actually receive the same batch, the same number, sometimes even on the same day at the same time, to see how they fared, right? So we look at all of that and we do the comparison of did those persons have the similar illnesses to the person who died or none at all? And we do that process of elimination to get to cause and effect. So Miss Zahra, tell me if I need to do any more or you're with me here.
Okay, thank you, Dr. Ennis. All right, so I'm with you, but you said at the end of the investigation, it's inconclusive, right? So sometimes, right, sorry. So just out of curiosity, how do you make, I guess, the public aware? Because in addition to this JLP counselor, of course, we had Bruce Golding, who was the former prime minister. He got vaccinated. He ended up in hospital. We were told for a recurring condition. I believe it, Michael Sharp too, vaccinated, ended up in hospital. Like, how does the public learn from the examples that we are seeing when we see high profile individuals who've taken the vaccine publicly, seemingly end up in the hospital soon thereafter? You know, and it just, how do you stage
so let me try.
Yeah.
Let me try. So once you get a vaccine and anything happens to you, it is labeled initially as a post-vaccine event. So if I take the vaccine today and I die tomorrow, my death initially is attributed to a post-vaccine death. Now, that's where the investigations begin. So my death could be due to a car accident, and it is still a post-vaccine death. So it is until that disaggregation is done, and you say, okay, so Melody Ennis got the vaccine, yeah, but it's a car liquor down. So it's not the vaccine really did kill her. Now, you have mentioned these high-profile persons. So first of all, my dear, just out of, and you know, out of doctor-patient confidentiality, we can't speak publicly to the details of any case at all. And a lot of times it appears as if we have glossed over, but I cannot speak to the medical challenges of a Mr. Bruce Golding or a Mr. Darren Wood. I can't do that. So I can't counter everything that you hear or see in the media. I cannot do that. I can tell you in a general way that persons with pre-existing conditions may have this outcome or that outcome, or we continue the investigations, and in a general way. But I cannot speak to the medical condition of anyone, of anybody, be it prominent or not. I cannot have that discussion with you. And therein lies the challenge, because it appears as if persons want specific details. So I would be saying that, okay, so Melody Ennis had 3 DVTs before and she had 1 after, so maybe it's not, or I can't do that. And therein lies the challenge.
Yeah, but it just seems to me, I hear what you're saying, but it seems to me like on COVID conversations in the past, I remember when COVID had all of this stigma attached to it, that there was like individuals that you would have on the COVID conversations that say, okay, I got COVID, and they were speaking out like the first time, for the first time. So it's like the Ministry of Health actually got persons who had an adverse, not adverse experience, just had tested positive despite the stigma. And so, it would be, I think, beneficial for us to hear from individuals who've received, I know that there was one person that you mentioned had an abscess. It would be good to hear from somebody who was in fact experiencing a severe adverse reaction to maybe Mr. Golding himself or whoever, to speak through what exactly happened, in their cases. And so, it does unsettle you. And if you're a member of the media, you automatically think about those things without being able to just brush them aside. You know what I mean?
Understood. And you have to also remember that I hear you and I understand, but you also have to remember that it's a person's choice to come out and speak. So I will ask you, Ms. Burton, can you please? And you say, no, I don't wish to speak about it. So we also have our challenges. We look at, because we want to be as balanced as we can. Some persons just don't want them business public, them go to hospital, them don't want to talk about it. But we continue to encourage and to ask those who have had adverse reactions to speak, because we mention a lot of these persons who are high profile, and some of them have not even ascribed their hospitalization to the vaccine, because they know they have pre-existing conditions that and they have had similar illnesses before. So they have not even ascribed it to the vaccine. It is the media that is drawing the link in some of the instances.
So thank you so much, Ms. Burton. I'm going to just ask you to pause there and we can circle back to you and just allow others an opportunity to also ask and join the dialogue and the discourse. So I'm going to go to Jamaica Observer, and then there was a question that was posted in the chat by Mr. Morgan that I will then read after that. So Jamaica Observer.
Hello, good morning, everyone. So Dr. Ennis, some are saying it is ill-advised to use the vaccine after it has expired. So does it still have the same level of effectiveness, even if it's expired? That's what I want to know.
Well, I don't believe we should be talking expiration, because the vaccines that we're using have not expired as yet. But just on a note of expiration in general, stabilization or stability studies are usually done on medications to see how long they remain in that stable state. And that is how we get the shelf life, be it 6 months, 9 months, or whatever. And periodic tests are done to see if it remains stable. And that is how expiration dates may be extended. Now, if the drug remains stable, then the efficacy will be just the same. But other studies or efficacy studies are sometimes done. But the first study that's done to extend a shelf life are the stability studies. But I don't think we are at the point where we should be speaking expiration at this time, because we are not using expired vaccines, and we won't use expired vaccines. So I think we can move on from that one.
Okay, so moving on to the question in the chat. Mr. Anthony Morgan was asking, for someone who contracted COVID-19, how long after recovery should they wait before taking the vaccine?
Okay, so if you were symptomatic for the disease, you were ill, and once you have recovered, once you are no longer having signs and symptoms, you are well, then you can take the vaccine. If you tested positive, but you were asymptomatic for the disease, Then once you have completed your quarantine period of 14 days, then you can get the vaccine.
Okay, Mr. Job Nelson.
I know Dr. Ennis said that, talk about the myths, but are you sure that it is the myths why Jamaicans not taking up the vaccine? And are there studies or polls being done to find out what are the reasons why the vaccine are not being accepted by Jamaicans at this point?
So yes, we have done polls. We continue to do same. We have done focus group discussions initially with the target populations, healthcare workers, the army, police. We have done those focus group discussions. We've also had some general discussions with the elderly, and we look at some of the things that they say. And one of the top ones is the speed which with the vaccines were made. Another one is just the general conspiracy theories of really and truly people think that it's trying to kill Black people and causing infertility, but more so just trying to kill off Black people. A lot of persons in our focus group discussions brought in the Tuskegee study that occurred in the States with syphilis, where the persons were not treated, and that's just a wrong point in history. So they just, some persons in general just say they don't trust the vaccine. They don't trust the manufacturers. They don't trust, believe it or not, they don't trust America, So those are some of the things, but I'm gonna ask Dr. Spence now, who is the organizer of most of those studies, to just share with you a bit. Dr. Simone?
Thank you, Dr. Ennis. So yes, we, as Dr. Ennis indicated, we would have done several different focus groups with different target audiences. We're currently undertaking one now, more specifically to look at vaccine hesitancy in different groups. But you would have outlined some of the major factors. I think also the misinformation and the disinformation, because we do have a lot of anti-vaxxers globally. And so when people get incorrect information, they get it through different WhatsApp groups and so on, they tend to latch on to this information. And so it's very important for us through the media and through our different types of mediums and platforms to help to give the correct information while encouraging persons to ensure they source the information from reputable organizations such as the Pan American Health Organization, World Health Organization, CDC, FDA, and these other bodies. And so it's a deluge of information from different sources, and people sometimes are not sure what to believe. And then also when we have sensational headlines, persons don't actually read the entire story, but just latch on to the headline without examining the background or the context or the story. And so they may have heard one rumor about something, and then they latch on to that, and that is what they run with. So having the sensitization sessions, and even through the different focus group, the different meetings and so on, we try to make sure that we infuse a lot of the information out there, the correct information, so that persons can have a better understanding and therefore help to reduce the level of hesitancy. And I think the more people that are vaccinated in our population and persons recognize that the benefits far outweigh the risks, will also help to prove for some persons, because I hear a lot of persons also indicating that they're watching and seeing, waiting and seeing what happens. So when this first batch run off, and if nothing happens to them, then they will go ahead and take the vaccine thereafter. And so I think, with time, we will begin to erode that vaccine hesitancy. I'm not seeing anything else in the chat at the moment. Zahra did indicate that she had additional questions. So let me go back to Ms. Burton.
Hi again. So a couple more questions about the J&J vaccine. Today, it's built on the same platform as AstraZeneca, and today the US, according to the New York Times, is essentially calling for a pause on the use of the J&J vaccine because of the same blood clotting issue. I believe that Dr. Ennis had said there have been no blood clot issues in the persons that have been vaccinated here in Jamaica last time. However, because we have seen abroad where those that are under 30, in some cases under 55, because again, today there were 6 persons who experienced it, all women 18 to 48, their ages. What is the government, the ministry's position on whether to start putting certain steps in place that would allow those categories of people to take something else? Is it your recommendation that these individuals take something else at this point? How are you treating this? Because clearly it's something that is to be taken with a level of seriousness.
Okay, Miss Burton. So how we move forward with recommendations and advice is really from the World Health Organization. So we await interim guidelines as to how we should move forward. And that happens certainly for us in the Latin America and Caribbean region through PAHO. So because a country, which is a sovereign state, makes a decision to pull, to hold, we don't go on those things. We go on the scientific evidence, the basis. We go on the reviews from the strategic advisory experts. We go on those recommendations. So remember, I said that the surveillance system is a robust system. So it recognizes any challenge that may happen. And countries, entities have the right to say, during our investigation, we want to hold. You would have noticed that that happened in Europe. In Europe, when the blood clot situation came up, certain countries went on hold immediately, right? They stopped, and that is their right. But at the end of the day, they had to restart because coming out of the experts' analysis of the situation, review of the facts, the correlation was not there, and therefore they had to restart. So we don't do the start, stop thing. We await the recommendations that are very clear, that tell us, as we have received recommendations on AstraZeneca, very clear that these things are noted. This is the evidence, this is the ratio, and at this time we believe we can continue. So we have not received any such information as yet to suspend the use of AstraZeneca, to stop its use in persons under the age of 30. We have not got that information, and we continue, because that's a trusted source that we use, that has been with us for years. So that's it. Until we have those instructions, because we don't have the capacity in Jamaica or the Caribbean to carry out those tests. We have to rely on a source, and the source that we have found to be credible over the years is the World Health Organization. So when the World Health Organization tells us, stop using AstraZeneca because, or do not use Johnson & Johnson, then we so will. But at this time, the recommendation from our trusted source is to proceed as we have been doing.
So even though you're not,
sorry,
so even though these countries are not 100% sure about whether there is full causation, because I know the European regulator, they had basically said there's a possible link, right? So even though it's not definitive at this point, you are still suggesting that everybody in each group continue to take this vaccine. I just want to be clear on that's what you're saying.
That is the recommendation even from Europe, even from that said organization that said it is plausible. Because don't forget the statistics now. It's 147 persons that developed clots out of 200 million that received the AstraZeneca vaccine in Europe. So when they did the initial math and looked at it, they actually categorized the various clots in different places. And for one set, you should see only 4 clots in the population, and they saw 8. In another case, I think they should see 27, and they saw maybe 34 or so. So they've done that, and they said that because they saw those marginal increase, then yes, it is plausible, and they continue to investigate. But don't forget, it is 147 persons to 200 million. That's the ratio.
So tell me this: when are you going to get the others like Moderna in for the people that have concerns about taking the AstraZeneca?
The vaccines in Jamaica, like everywhere else, is dependent on supply and demand. And in spite of the hesitancy, in spite of everything that we are having, the demand for vaccines across the world way, way surpasses the supply. So when it's offered to us, when we can get it, we will get a variety. But for now, and it's interesting, when you look at the manufacturing companies for vaccines, the great big USA is doing what we know, passing, christening, picnic fuss. So the USA that makes Pfizer and Moderna and Johnson & Johnson are vaccinating their how much a million population before they give 1 ounce of the vaccine to anywhere else. Okay, so that's just putting it in perspective. Other countries that manufacture vaccines have said, okay, let us share with the world. And a bird in the hand is better than 2 in the bush.
All right.
I do
pause right here because there are other persons now that have asked questions, and then we'll circle again. So just so I'm going to go back to Jamaica Observer, and then I have a question in the chat.
Okay, I just have 2 questions. So this would be a follow-up. I'm aware that the vaccine will have expired today, and the CMO warned against using it after the expiration, and Dr. Maurice Guy also explained that the use of the expired vaccines would put the population at risk, and we would lose the protection of the AstraZeneca. So I wanted to know, what would it cause a toxic reaction, and what are possible or potential side effects?
Miss, we're not going to be using expired vaccines. Full stop.
The other question I have, has the ministry considered what it will do if we have a vaccine supply issue in the future, and for whatever reason, and have to choose between giving more people their first jab or giving a second jab to others?
Well, all of those things have been looked at. We continue to have bilateral talks to source vaccines, and so far, vaccines have been coming in tranches that are able to supply our targeted populations. So we continue to work with our stakeholders and partners, like the rest of the world, and continue to lobby that there is no halt in the vaccination program. It's really something that we take day by day, week by week. We have not come upon those hurdles as yet. I know it's important to think about them, but I don't think we should detain ourselves with, it hasn't happened. It don't look like it will happen. So I don't think we should detain ourselves with thinking that, yes, it's going to happen, what we're going to do. So far, we're getting vaccines, we're managing to do the target populations, and I think we should just continue to pray that we'll be able to vaccinate our entire population.
All right, from Mr. Anthony Morgan, Dr. Ennis mentioned that the second dose of the AstraZeneca vaccine would not be offered to persons who develop severe allergic reactions to the first dose. Would another vaccine then be recommended for full protection for those individuals, perhaps the one-dose Johnson & Johnson vaccine?
No, sir. We are not going to interchange, so they will not get the other dose. And that brings us to the important point of persons who can receive the vaccine, must receive the vaccine, because indeed there are those among us who can't. And it is only until we can form that shield around them, enough of us are so vaccinated that the germs cannot get to the most vulnerable that really can't take the vaccine. We have to protect them, right? We have to form that circle around them. So those persons who have the severe allergic reaction will fall into that small category of persons who genuinely cannot take vaccines.
All right, thank you. I still see Mr. Nelson's hand up. So Mr. Nelson, is it that you have another question or your hand was up from before?
I do, yes, I do. It's really a follow-up to my question and some that Zahra asked. Does the ministry know or have some form of a clue as to how much of a role or how much of a factor the AstraZeneca vaccine plays in the Jamaican hesitancy? The fact that it has so much issues around the world, how much of a role that plays in the hesitancy of Jamaicans?
I don't know of any specific study that was done, but just from feedback on the ground, it is not the AstraZeneca vaccine in particular that the hesitancy is around. It's all COVID-19 vaccines. Persons it don't matter. That is AstraZeneca. It's all the COVID-19 vaccines that the hesitancy is around, and it is spilling over into actually other vaccines in the vaccination program. So Dr. Spence, I don't know if you have any more information.
No, we don't. It's general hesitancy, as you have said, around all vaccines. The information about the possible association of blood clots did for a little time to, start to factor in, but not in a major way. So they may have mentioned it, but as I said, most persons are looking at having seen other persons being vaccinated and nothing happening to them. They are reassured, and then they themselves want to be vaccinated for the most part. So, Ms. Burton, back to you.
Hi again. On the point of the effectiveness, right? So I think it was Pfizer that came out and said that the effectiveness would be up to 6 months. And I was just curious. I don't remember seeing anything, and maybe there exists, I just didn't see it, sorry. What's the time period for the AstraZeneca? And how often will we have to be getting these vaccines is the guidance that you've received so far? And then I still have another question after that, but what's the effectiveness of the one that we're taking, and how often will we have to be taking it? A couple times a year? What's the deal there?
So first of all, there's a difference between effectiveness and length of how long, how sustained the what is it now? How sustained it will be. So one, for none of the vaccines that have been granted emergency use authorization, there is no information on any of them for how long they will remain potent in the body. So we don't know that yet. However, there are some very preliminary studies coming out of it's Italy and China, some very preliminary studies coming out to say that the vaccines may last, this artificial immunity may last for about a year. And we may have to take the vaccines like how we take the influenza vaccines on an annual basis. But at the current time, we do not know.
So this is something that we might have to be living with every year, may have to be living with every year.
We may just have to. Yes, that may so be.
Wow. Okay, and that's an expensive situation for the government, clearly. Just out of curiosity too, when we go to the ministry's website, I know you guys said that you have a severe adverse event reporting system, like there's a form, and I saw a form, not sure if it's the right form, but I saw a form on your website. But what I'm not seeing, when I go to the CDC website, for instance, you can actually see, okay, all the different adverse effects that resulted, you know, after having taken the vaccine, whether or not it was caused by the vaccine. But there's like a very public way to look to see what's happening on the ground. Whereas in this case, I feel like we have to be coming to you to ask, have there been any blood clots yet? You know, how can we assure ourselves without having to come to you guys directly that we can actually see what's going on in our population? Just like we used to get in the very first instance where we, you know, had a male, you know, 4 males got COVID, you know, it was more explanatory. How can we get a more robust system so that you guys are seeing it, it seems, but we are not?
That one is simple, work in progress. You see, there is the business of reporting what we call ESAVs, or events supposedly attributed to vaccination or immunization. So there's a reporting channel, and it's very difficult when countries begin to expose everything. So we have seen 10 headaches and 5 vomiting, and at what point do we say they have resolved? So it is all of those issues why, what you call it now, it's really personal medical information that is not so shared, and it's not Jamaica alone. On the CDC website, they have listed more things, and they haven't really said how many of each they have seen. It's just a listing of what may happen, but it's a work in progress as to how best it can be reported, because, you know, once we report something, then we have to report a follow-up and a resolution, and it really is a work in progress to see how more informed the population can be.
Okay, so when you report it to international entities, who are the international entities, and could we retrieve the information from them?
All right, so there is a reporting system, and that takes place through the Standards and Regulations Unit in the ministry through its pharmacovigilance arm. I don't have the website on hand just now, but I'm sure you can get it through the pharmacovigilance arm as how they report, not how, but who they report into and where it goes. Dr. Spence, maybe you can remind me. There are three international agencies, and I think those documentations are public. If you hang on and ask more questions, I guess I can try and call someone to get.
All right, so since you're going to do that, I will ask another question.
Sorry,
Unless
Ms.
somebody else.
Can I just allow Ms. Hibbert?
Okay.
She just had her hand, just raised her hand. So let's give somebody else another opportunity. Ms. Hibbert, can you go ahead? And then we'll circle back to Ms. Burke.
Yes, Dr. Spence. My question is for Dr. Ennis. I have 2 questions. So the first one, I know in your presentation you mentioned the myth about the vaccine causing infertility in women. However, in terms of women who are breastfeeding or nursing, can they take the vaccine? And the second question, Over the weekend, there has been some circulation on social media. Even our minister retweeted some things about it to say that men who have contracted COVID-19 stand a greater chance of having erectile dysfunction. But is there any evidence to show that the vaccine actually reduces, the chance of that happening either way?
All right, so there is no evidence that the vaccine affects the erectile function of men. There is also no evidence that the vaccine reduces the sperm count or affects the male fertility. So there is no such evidence in the thousands of persons that were studied in the phase 3 trials. That's not been noted. So I can't comment further on that. Now, the recommendation for the administration of the vaccine to persons who are nursing as well as to pregnant women is for persons who are super exposed. They are in the population of most at risk, as well as having comorbid conditions. So that group that is stated would be healthcare workers and persons who are very, very, very at risk. Now, there were no studies done on pregnant women as well as on children, because for any medicine or vaccine, we do not do clinical trials on those persons until millions and millions and millions of persons have received the medication. All right. But the recommendation for them to get it was based on some facts. One, the platform, and we're talking AstraZeneca specifically because that's what we have. The platform that is used to make the AstraZeneca vaccine. One, it is non-replicating. Therefore, it does not cross over into the placenta and it does not cross over into breast milk. So the fetus won't have a problem and the baby won't have a problem. And that's just based on the platform that's used to make the vaccine. Then when you look at the risk to pregnant, super exposed persons, when pregnant people get COVID-19, they do much worse. And they also tend to have premature babies. So they may die and their babies will be premature without a mother. So when you look at that risk compared to the fact that we know that it's not going to go over into placenta, it's not going to go into breast milk, although we do not have the thousands of persons in a clinical trial, the recommendation is that the risk of taking the vaccine is much lower than the risk of getting COVID in that population. And so that recommendation to give the vaccine was made. Luckily, I can say that because over 400 million persons have received the vaccine, they have now indeed started looking at pregnant women, children, and persons with autoimmune conditions in clinical trials. So in the coming months, we should be able to get information on those specific populations.
All right, thank you so much, Dr. Ennis. So this will be the final round of questions. We had allotted 1 hour for this discussion, and I know we started a little late, but we need to wrap up because we have to move on to other meetings that we have planned for today. And so I'm just going to ask for the final round of questions from everybody in general, but we'll start off with Ms. Burton.
All right, thanks again, Dr. Spence. Dr. Ennis. So I have 3 more questions for you. All right, so this policy that you guys put out, well, I don't know if it came from you guys, but this is the question, did it come from you? Where the $10,000 was supposed to pay people to take the vaccine, pay people that took the vaccine, I'm sorry. That policy, it was for the seniors, that policy came from the Ministry of Health?
No, ma'am, you will need to speak to the Ministry of Finance and the Public Service about that.
Okay, all right, next thing. How are you, let us say you told the audience last week that we don't have any blood clots in terms of adverse reactions. But how is the WHO guiding you in terms of how to screen for the individuals to ensure that those, you know, I don't know if the studies are conclusive as yet, because people are still trying to understand why these blood clots occur in the first place, like in the brain. But have they given you any guidance as to, okay, when you sit down there to get screened before you get the vaccine, the kind of questions you should be asking different clients before giving them the vaccine so that that is ruled out or that is minimized, the possibility of getting that blood clot?
Well, first of all, they have not said that the vaccines will cause the blood clots, and therefore there is no ruling out to say that if you have this, then it means you can't get it because you'd get a blood clot. So you have to start from, you go back to the very basics of it. That recommendation that the vaccine causes a blood clot is not there. So I can't screen, so there's no recommendation for screening, because whether you have had a blood clot in the past, whether you are on blood thinners, there is no recommendation that you should not take the vaccine, because the cause and the effect has not been conclusively studied. So there is no screening out of anyone at this time, not yet.
Okay, and then going back to one of my original questions, and I guess it's the last of it. How are you screening for the COVID-19 prior to vaccinating? Like, let us say, for instance, they're asymptomatic. How do you deal with?
No screening. There is no screening. Vaccines there, and that is for vaccines in general. We do not test persons if they have the disease. Vaccines are basically preventative. So we don't test people to see if they have it and then give them or don't give them.
That's not my question though. My question is, yeah, my question is, and maybe it will be the same answer, but I just want to be clear on what I'm asking. If the CDC is saying that if you currently have COVID-19, you should not get the vaccine, right? I'm asking you, is it part of the ministry's process to ask questions or to test for COVID-19 prior to being vaccinated in accordance with what the CDC put up on its website?
So we do ask if you have had COVID. We do also ask if you had a confirmatory test. We do not test persons prior. If you say you have had a confirmatory test and the date was last week or the week before, the PCR test, we assess you for symptoms. Do you have the loss of taste? If you have any symptoms, first of all, you should not be in the vaccination center. You should be isolated. But we know that there are persons who will take 1 million Panadol and whole heap of antihistamine and turn up. And believe you me, ma'am, I have seen that in our vaccination centers. Okay? So we do ask questions. We also continue to expect persons to be honest, especially with their doctors and healthcare providers. Maybe that's how come I found out that 1 and 2 persons sitting in my hall to be vaccinated actually tested positive and did indeed douse themselves with medication to come in. Okay, so we do ask the questions. We continue to beg of the nation to do the correct thing. But with regards to having a test done before you get the vaccine, the answer to that is no.
Thank you, Dr. Ennis. And then just to follow up, you were going to call somebody during this call.
Oh, I don't call yet. I have the number right at my thing. I just need to press send.
Oh.
Because you're not asking me questions. Me couldn't just, Miss Burton, does that mean now that you're not going to ask me any question on the next COVID conversation? Huh? Ennis?
What are the chances of that, Dr. Ennis?
Boy, I believe it's zero. I believe it's zero.
Yeah, answer your own question.
All right, thank you so very much. So while Dr. Ennis checks on that, we're going to just wrap up at this point in time. And so I'm just going to ask our Director of Health Promotion and Education just to highlight a few things that we would want our media partners to do, you know, your role and your responsibility at this time to assist us in getting the correct, accurate messages out there to the wider population. Ms. Fogel?
Okay, good morning again, ladies and gentlemen. Just to say, you know, you are a critical component of promoting health. You know, building partnership with media is very critical to us, and we want to certainly thank you for the many ways that you have made yourselves available and accessible in getting our critical information out. Dr. Ennis has emphasized the importance of vaccine uptake in our population. And so we just continue to look to you for the different ways that we can partner to get this information out, accurate, of course, timely information. It will require, of course, working with our health teams on the parish level, the regional health teams, and here at the national level. You know, continuing to facilitate or the interviews, as so many of you have. There's innovation and creativity that you have, and persons look to you to get, you know, information, and we really just want to solidify that, especially at this critical juncture in our population and in this whole process of the pandemic. You play such a critical role in helping us to slow down this pandemic in terms of, because we understand that the vaccination does make an important role in slowing down the pandemic, and you are who we are going to rely on a lot in terms of how you help us in targeting our audiences, because we know that we're speaking to so many persons. We have the different age groups, and they all have their, you know, different beliefs, values. They have their different ways of approaching things, they have different channels that they reach. And so we are asking you to just come alongside us, as you have been doing, but just in a more targeted way with our different age groups, with our, you know, different geolocations, just getting the word across. As we say, you have been doing an excellent job in helping us to do it, and we just seek your support in helping us get innovative ways of doing it. Persons look to some of you as their ambassadors, so even in the way that you use your programs to help us promote these messages. You know, we welcome that, and we thank you for those who have been doing that on a consistent basis, you know, helping us in terms of developing some of the dramas that, you know, persons will look to and get the message a little bit quicker. We just look to you, and we again thank you for the ways you have already been doing it, and look forward to an even closer partnership as we continue to roll out our vaccination process. Thank you so much.
All right, let me jump in before the host takes over. Miss Zahra? Miss Zahra?
Yes, Dr. Ennis, sorry.
I have our pharmacovigilance officer online who will answer your question. She's Mrs. Julian Gemont. Mrs. Gemont, please listen for Mrs. Burton's question. Go ahead, please.
Okay, no, this was just to know, like, in terms of us being able, as members of the media and as members of the public, to be able to see on your website or to the international entities that you have actually shared this information with, what the different adverse events have been, how many people, what kind of background, whether they're male, female, age group, that kind of thing. Where would we find that as members of the media on a more consistent basis, rather than having to come to Dr. Ennis to ask?
Okay, good morning. Thank you for the question. Unfortunately, where I stand in terms of submitting information to the international body, which is the WHO Program for International Drug Monitoring, the media wouldn't have direct access to that.
What about whether you would share it with us then? On a consistent basis.
Information could be shared, and I normally share it through Dr. Ennis.
Okay, so Dr. Ennis, we can get it from you on a more consistent basis rather than having to come to you, like specifically, you could send it out through Petrie and Mr. Stephen Davidson.
We'll look at putting something together. Remember, I said work in progress. Do you remember that one?
Right, so this is a suggestion for the progress that we're hoping to achieve.
The other question, though, remember earlier, was who you report to. What's the name of those entities that you submit to, Mrs. Jeffrey?
Yes, please.
Okay, we submit report to the World Health Organization Collaborating Center, that's the Uppsala Monitoring Center.
Can't hear you, can't hear you.
Let me see if I can take off my mask.
I don't want you to do that. I don't want you to do that.
No, I'm in a confined area.
Oh, okay, thank you.
Away from everybody. No, what I was saying is that we report to the World Health Organization Collaborating Center, which is the Uppsala Monitoring Center in Sweden. And we do it in
I'm not hearing a word.
Okay.
The Uppsala Monitoring Center.
Did you hear Uppsala Monitoring Center?
Uppsala Monitoring Center, okay.
In Sweden. Go ahead now.
And it's a global database called Vigibase.
Vigibase.
Digibase.
Vigi.
V-I-G-I-base.
Okay.
Vigibase. So that's where we enter our data. Vigibase.
So it's WHO, Uppsala, and Digibase.
Vigi, V-I-G-I.
Right, all those three.
It's one thing. The Uppsala, the WHO Collaborating Center, which is called the Uppsala Monitoring Center.
Oh.
Uppsala Monitoring Center.
Oh, okay. Thank you.
All right. Thank you so very much, Mrs. Gemont.
Okay, then.
All right, thank you, everyone. So it's just for me to say once again on behalf of the Ministry of Health and Wellness to say thank you very much to our media partners for participating in this session, and thank you for staying with us for so long. It does indicate your avid interest in this particular topic and your commitment to helping us and playing your active role in helping to keep our Jamaican population well informed. And it would be remiss of me not to say that although we're in the vaccination process, to remind our population as well to ensure that social distancing, that is keeping our physical distance, as well as washing our hands or sanitizing, and remembering that vaccination is one additional tool in our armory that will help us to overcome this pandemic sooner rather than later. And so we want everybody to be an active part of this process, as the benefits far outweigh the risks. So thank you everyone for being with us, and have a good rest of day, rest of work week. And we look forward to engaging with you in different avenues again post this. Thank you and have a good.
Thank you everyone.
And thank you as well. Thank you very much.
Bye, Zahra.
Bye, Dr.